Good afternoon, everybody. It is my great pleasure to give a talk today. I'd like to thank the committee member of AIOC for kind invitation. My name is Shizuka from Osaka University, Japan. So keratoconus is a progressive corneal ectatic disease, typically onset in second decades of life. It is characterized by steepening, distortion, and apical thinning of the cornea, leading to visual deterioration due to the irregular astigmatism. These are the typical clinical keratoconus signs. If you see these signs as a slit lamp, the keratoconus diagnosis is very easy. But however, there are many cases without clinical keratoconus signs. In such cases, we have to rely on corneal imaging. Right now, there is variability in diagnosis and terminology for keratoconus, especially for if some eyes don't have any clinical keratoconic signs, but have some kind of signs in corneal imaging, subclinical keratoconus or keratoconus suspect or frumiferous keratoconus can be used. But there is no definite consensus for the definition. Let me revisit the corneal topography and tomography. It is very important to recognize that corneal topography can be characterized for anterior corneal surface only. However, corneal tomography can characterize both anterior and posterior corneal surfaces. Currently, even when the tomography-based imaging techniques are used to obtain the corneal shape images, sometimes some people say corneal topography was used, but in this way, recently corneal topography is used, such as corneal shape imaging. I'd like to mention this just in case. Swept source OCT have been introduced recently. I believe many people are using already, and this has a higher speed and higher sensitivity. Especially anterior segment OCT is powerful even when the keratoconus has severe scarring or haze, or if the keratoconus is advanced, it can actually image both anterior and posterior surfaces clearly. This shown here is the case keratoconic eye after acute corneal hydrops. If usually corneal haze or corneal scarring makes the imaging very, very difficult, and usually we cannot actually get the good image from that eye. But the OCT uses the 1310 nanometer wavelength, so it can penetrate opaque tissues and provide clear images. This is the advantage of use of OCT. As you know, frumiferous keratoconus is a fellow eye of very asymmetric keratoconus, which does not present with clinical or topographical signs, while one eye manifests with clinical keratoconus. Sometimes this is actually called as fellow eyes of very asymmetric ectasia. Right now, there is a variability in diagnosis and classification of keratoconus. As I said, there is a kind of a mixture of subclinical keratoconus or keratoconus suspect. So to avoid such kind of confusion, I'd like to propose a very simpler classification based on clinical sign as the slit lamp and topographical sign based on the placebo topography. So clinical keratoconus, topographic keratoconus, and pre-topographic keratoconus, and normal eye. Sometimes this is, as I mentioned, this is called as very asymmetric ectasia with normal topography. But right now, I'd like to go with pre-topographic keratoconus. This is a classification based on slit lamp and topographic sign. You don't need any special devices. You can just classify based on your slit lamp and placebo topography. As I mentioned, normal has everything is okay. Pre-topographic keratoconus has no sign at the slit lamp and placebo topography, but this is the fellow eye of clinical keratoconus. Topographic keratoconus has an abnormal sign at the placebo topography. For the clinical keratoconus, we classified into 3 groups. One without nose scarring, and number 2 is keratoconus with scarring in the anterior stroma. And number 3 is a clinical keratoconus with scarring in the posterior stroma with history of acute hydrops. This is a kind of severe type. I'd like to mention about the Fourier analysis with OCT. Fourier analysis is a kind of useful tool with anterior segment OCT. So the corneal dioptric data can be divided into 4 components: spherical, regular astigmatism, asymmetry, and higher order irregularity for both anterior and posterior corneal surfaces. So actually, asymmetry components and higher order irregularity are the components of irregular astigmatism. This is an example of keratoconus. Let me, please forgive me, this is a kind of very busy slide. Actually, it looks like mandala. So I actually show the representative Fourier map cases from the representative case from all 6 groups. So you can see the anterior Fourier maps and posterior Fourier map. As I mentioned, purple is a normal, and the red is the color, the severe the keratoconus. So if you look from the up and low level, you can see the kind of significant actually color changes with the severity of keratoconus. This is a scatter plot. So for the to see the relationship between the corneal thickness and Fourier indices. So the upper level is the anterior Fourier indices from the anterior corneal surface, and the lower level is the Fourier indices from the posterior surface. You can see the kind of very good, nice relationship between the corneal thickness and the Fourier indices. Again, the redder the color, the keratoconus is severe. You know, superior inferior power asymmetry is a characteristic of keratoconus. So visual impairment due to the irregular corneal astigmatism is actually by the increase in coma, kind of superior inferior asymmetry. So we focus on the corneal asymmetry component from both anterior and posterior components. When we look at the relationship between the corneal thickness and the asymmetry components, you can see the nice relationship between these parameters. When we look at the discriminating ability of the Fourier indices between normal eyes and pre-topographic keratoconus, actually FFKC, posterior, the Fourier indices from the posterior cornea asymmetry component is shows the best ability. In summary, Fourier analysis using anterior segment OCT can evaluate anterior and posterior corneal irregular astigmatism of various keratoconus stages, from very mild to advanced, including severe cases with corneal scarring. Thus, this distribution data enabled us to visualize an increase in all Fourier indices in either the anterior or the posterior cornea as the keratoconus severity increased. Thank you for your attention.
Thank you, Dr. Ko. That was a very interesting talk. And now you're using the Cassia 2 topography in all cases. Are you using that, or are you using that in all cases? The Cassia 2 topography map
So actually, we are using Cassia 2 topography by Tome. Yes, Cassia 2.
by Cassia 2
Cassia 2, yes.
only.
No. Of course, we actually measure all the patients with other devices, but in this study, we just actually focus on the OCT, anterior segment OCT, just Cassia 2. Of course, and in the next study, we'd like to actually thinking about the investigate to relationship with from the parameters from other devices as well. But the important thing is actually, as I mentioned today, OCT can actually analyze the topographic data even in the advanced cases, because other blue light like from the rotating shine proof camera cannot actually visualize the corneal parameters in the advanced cases or hazy cornea.
In case there's a disagreement between pentacam K1, K2 values and the Cassia 2 K1, K2, which would you choose between the two? If there's a disagreement in the K1, K2 values and the axis, for example, you have a patient for toric IOL or something like that, which would you choose?
So you mean the Cassia 1 or Cassia 2?
If pentacam and Cassia 2 they do not agree with each other, the reading, what would you choose between the two?
Oh, so you mean that if the Cassia 2 cannot dictate the imaging? I think this is a very, very advanced cases. So most of the cases, we can actually get the data. Of course, these data, we already actually check the quality of the data. All okay, yes.
Any questions from the panelists, Professor Jain, Dr. Basar, Dr. Chintan? Any questions?